On behalf of the MDRN Collaborative, my name is Irina Yudin. In Module 2, we will start getting into procedure-specific content. This tutorial will deal with central venous lines. I think this is the most common bedside procedures we do in medical ICU. Remember, as we move through this content, to always consider and incorporate the standards of procedural safety in the care that you deliver. So, what is a CVL? And what veins are considered part of the central venous circulation? A CVL, like the name suggests, is any intravenous catheter that accesses a central venous circulation. The tip of the catheter sits in either superior vena cava or inferior vena cava. The majority of the catheters placed in our unit are placed in a superior vena cava by the way of the internal jugular vein. The subclavian vein is associated with higher procedural safety risk, and that's why it's rarely accessed by our team. The IVC is more commonly accessed by the way of the femoral vein in an urgent situation or when IJ, internal jugular access, is not feasible. Femoral lines are associated with the higher rate of infection and are placed in an acceptable alternative when necessary. So, why do we need to place these catheters? What are the indications for the central venous access? Some of the indications include hemodynamic monitoring. CPP pressures can be obtained through lines placed in SVC, as well as through PICC lines. A couple of things to consider with the PICC lines. Because of their length, the integrity have higher resistance than the CVL catheter. As a result, the CVP pressures reads approximately 1 to 2 millimeters of mercury higher than the CVPs taken through a standard triple lumen catheter. Also, be aware that the waveform on PICC lines can be dampened, making the number less accurate. You can offset some of this by following the PICC line flushing guidelines carefully to optimize the waveform and integrity of your numbers. So, do your square wave test first to determine whether your waveform is acceptable, and zero your transducer before obtaining the CVP reading. The CVP tracings are just another clinical parameter to help evaluate the patient's fluid volume status, so using a PICC line to trend data can be helpful. Other hemodynamic parameters that can be measured through include PA pressures, cardiac output, cardiac index, systemic vascular resistance, and peripheral vascular resistance. These can be obtained through Swan-Ganz catheters. Other indications for CVL catheter include hyperosmolar solutions like TPN and 3% hypertonic soiling. And other indications include large volume infusions, vesicants like chemotherapy, vasopressors, irritants like potassium chloride, medications with extremes of pH, such as dilantin, need for long-term IV access, including antibiotic therapy. Amiodarone. We have two concentrations for this drug, and the higher concentration, 500 mg into 50 cc's, must be infused through the central line only, and need for multiple medications. We encounter most of these situations routinely in our critically ill patients. So, what types of central venous catheters do we encounter in ICU setting? Well, we have several types, including non-tunneled and tunneled catheters, implanted ports, and PICC lines. Non-tunnel CV catheters are any catheter that is placed into central venous vessel that are fixed or sutured at the insertion site. Some of the examples are triple lumens, Cordis or Swan-Ganz, Maherker, and a PICC line. We use these most commonly in ICU setting. These are short-term use and are generally removed within days, up to 2 weeks from the time of insertion. In fact, we evaluate oral CVLs every shift for necessity and document that in a CS link. This is simple quality assurance measure to reduce infection risk to our patients. If the patient no longer has indication for use, we need to communicate that to the physician team and advocate for line removal. A tunnel central venous catheter is any catheter that is placed in a vessel from under the skin to a separate exit site. Passing the catheter under the skin helps to prevent infection and allow for longer-term use. Examples include Hickman catheters and permacats, or tunneled PICC lines. A PICC line is almost its own category, as these lines are placed in a vein in the arm and advanced into a central venous system. These can be tunneled or non-tunneled, as just described. An implanted port is a surgically implanted device to access the central venous system. Examples include passport, placed in the upper arm, or portacath, placed in a chest. Let's take a closer look at the catheter we utilize most frequently, the multi-lumen CVL. Remember, this is non-tunneled, acute care catheter that is generally in place anywhere between 7 to 14 days. The triple lumen catheter that has 3 access lines. The white hub is the proximal port. This means that the exit site for this line is the closest to the hub of the catheter. Think of it as the close proximity to the hub. This line should be used for blood administration and blood withdrawal. Makes sense, so there is a shorter distance on this lumen and less chance for clotting, and you won't be pulling back diluted blood from IV infusion during phlebotomy. The middle port has a blue hub and exits in the middle of the catheter between the proximal and distal ports. This should be your first choice for continuous central line infusions. If you have TPN or lipids to give, you should infuse through this port. Finally, the distal port. This one has a red hub and the port exits closest to the tip of the catheter. This is really important to know because this is where you're going to want to hook up your CVP monitoring to view the pulsatile waveform and achieve accurate numbers. Short-term infusions like piggyback and IV push meds can be given through this line. Here are some general guidelines for CVL care. Following these guidelines is a critical part of preventing CLABSI and mitigating iatrogenic complications of line placement. So the must-dos include: maintain a clean occlusive dressing, removing the Curos caps or scrubbing the hub for a minimum of 15 seconds before accessing the catheter, changing hub connectors every 96 hours or when blood has been aspirated through the connector, and with all CVL dressing changes and tubing changes. These are all key considerations when trying to determine a root cause for the development of eclampsia. We will review sterile dressing changes later in the program. There are some definite don'ts. Please do not leave tubing connected to your CVL if it's not infusing. This can result in clotting, dampened waveform, inaccurate CVP readings, and loss of access. Also, do not leave the white caps on your pressure tubing. These caps are intended for setup only. They allow you to flush the tubing while maintaining sterility at each open site. They're patent caps and must be replaced with closed yellow caps when tubing is all primed. Do not let your pressure bags run dry. All normal saline pressure bags should be changed every 24 hours. No IV bag, flash pack, or medication should be hanging at the bedside for greater than 24 hours. Please check these during your SBAR. The Maherker is another commonly used line in our ICU, and this CVL is used for dialysis and apheresis. If you're lucky, the one you will be using will have a pigtail lumen, and this can be used for infusions, blood draws, and CVP monitoring. The standard Maherker is a 12 French and has two 15-gauge dialysis ports and a 19-gauge pigtail. After use, dialysis ports are flushed with normal saline and then impregnated with approximately 1 cc of heparin, concentration 1000 units to cc to prevent clotting. Anytime you need to place heparin in the line, you will need a specific doctor's order. We are usually just doing the double check for dialysis nurses. However, if you are around supporting the placement of the line, once you have chest X-ray confirmation, you will need to flush the catheter and put heparin in the line. If you were to need the central access in the emergency, it is important to pull back and discard a minimum of 10 milliliters of blood before flushing with normal saline to prevent a bolus of heparin from reaching a patient. The Maherker comes in different sizes. If the catheter is being placed in the right IJ, the shorter 13 cm curved catheter is recommended to prevent a pneumothorax. If the left IJ is selected, you will need longer 16 to 20 cm curved catheter. Think of it as left needs to be longer. If femoral access is chosen, the 16 to 20 cm straight catheter is needed. The flushing protocols are an important nursing responsibility to maintain the integrity of the catheter. Here it goes. This should be a review for all of us. CVL. Flush with 10 to 20 milliliters of normal saline after each use and as needed. Use a push-pause technique to help create turbulent flow and maximize clearance of the catheter. It is important to note, use only 10 cc syringes or larger to flush the catheter in adult patients. Otherwise, smaller syringes cause higher pressure during the flush and can rupture your catheter. PICC line. Flush with 10 to 20 milliliters of normal saline. A pigtail should be flushed with 10 milliliters after infusion and 10 milliliters after blood draw. When not in use or locked, inject 2.5 ml of heparin, concentration 100 units to ml, to maintain patency, per MD order. Maherker. Flush with 10 to 20 milliliters of normal saline. A pigtail should be flushed with 10 milliliters after infusion and 20 milliliters after blood draw. When catheter is not in use or locked, such as after dialysis, instill heparin, concentration 1000 units per ml. The amount that will be ordered by the medical doctor and instill may be catheter dependent. Check the venous and arterial ports and you will find the catheter volume displayed in mLs printed on a port itself. It is usually somewhere in the neighborhood of 1 to 1.5 milliliters and is based on the length and lumen size of the particular catheter. That is why it varies. However, it is not uncommon for the providers to order a standard 1 milliliter flush. When accessing a Maherker or any dialysis catheter, always withdraw a minimum of 10 milliliters for discard before flushing, so you do not inadvertently give a bolus of highly concentrated heparin. Portacath or passport. Portacath or chest catheter requires 10 milliliter flush after infusion, and passport or arm catheter requires 20 milliliter flush after infusion. When not in use or locked, inject 5 milliliters of heparin, concentration 100 units to ml, to maintain patency, per MD order. The tubing change protocols are an important nursing responsibility to maintain the sterility of all catheters. Once again, this is just a review. Regular IV solutions. Tubing change should be every 96 hours. TPN without lipids, tubing change 96 hours. TPN with lipids, even if intermittent infusion going through TPN tubing, change every 24 hours. Chemically high dose infusion, change every 24 hours. Propofol tubing change should happen every 12 hours. If you encounter tubing not labeled for a change, it must be changed immediately. Preparation for the CVL insertion will mean getting your gear together. I reach for the necessities first: procedure card and sonosite. Check to make sure the catheter you need is on the card. Otherwise, get a backup in the med room or clean utility room. Now, if you see the resident wandering around the clean utility room purging these supplies, remind them of a procedure card. They're just making more work for themselves, and they're not aware of the benefits of the card. Then consider lidocaine and monitoring equipment. Double check with your proceduralist to see what they want for anesthetics. Most will ask for 1% buffered lidocaine in a 2 ml vial. Then gather your monitoring equipment if needed. Before going any further, remember your standards of procedural safety and complete your pre-procedure care. Consider past medical history and what may place your patient at increased risk. Do they have a coagulopathy? Do you need to take any steps to mitigate bleeding risks? What about allergies? Be sure to check with your patient and family to explain the procedure and see if they have any further questions. Check to make sure that proceduralist is credentialed to perform the intervention. If you have trouble accessing the database for privileges, you can ask the proceduralist to log into their own account and view them from there. So please, never assume these important pre-procedure care items are complete. You have to check. Other units, institutions have varying policies, but we are obligated to uphold our standards of care. Finally, be sure the consent is signed and initiate a timeout before the procedure gets underway. Like we talked about in our first tutorial, these intra-procedural interventions are largely targeted at maintaining sterility and safety. Start by making sure you have everything you need for the procedure in the room, including any monitoring equipment and a CVL dressing kit. Then wash your hands for a minimum of 15 seconds, like scrubbing the hub. Then put on cap, mask, and gloves. Maintain sterile procedure with all assists. Be sure to perform a wire count before the initiation of the procedure. 1 wire is prepackaged with the standard CVL kit. Remember to perform the count again whether an additional wire is added to the sterile field. This is a collaborative effort initiated by nursing to maintain safety. If the proceduralist is having trouble obtaining access, please advocate for your patient's safety, working together to identify a more experienced provider who can assist with the line placement. Research has shown that when provider goes beyond 2 attempts at placing central access, the risk of complication increases 8-fold. We work in a teaching environment, and it is not uncommon to have relatively inexperienced providers performing these procedures. Once access has been achieved, be sure to confirm the position of the catheter, first by blood return and later with a chest X-ray after the procedure. Femoral lines are exception. A chest X-ray will not confirm placement here, the blood return will. If there any concern that the blood may be arterial, hook it up to a transducer to be sure, and if not an arterial waveform, send off an ABG. This may sound unnecessary, but many of our sickest patients are very hypotensive and don't always have high pulsatile pressures. So there are instances when this may be necessary. Nursing must initiate a final wire count at the end of the CVL procedure, ensuring all wires used in the procedure have not been retained. Be certain that needle-free connectors are placed on all ports and are flushed with 10 to 20 cc of normal saline. Place a dry, occlusive dressing. The Primapore frame dressings can be found in the procedure cart and a CVL dressing kit. Perform close monitoring post-procedure and every 4 hours thereafter, looking for hemostasis, circulation, sensation and movement, along with signs and symptoms of infection. These assessments are part of your CS Link every 4-hour documentation. So if you put a line in, make sure you have added these assessment items to your flow sheet, if they don't already exist. Complications. We don't approach our procedures with the expectation that we will have a complication, but we must be prepared for how to assess and how to treat them effectively to minimize risk and injury. So here they are. I will briefly point out the main initial symptoms you may encounter. If you're not familiar with some of these conditions, I recommend that you do self-directed learning to get up to speed on these. Cardiac tamponade, sudden tachycardia, low blood pressure, and narrow pulse pressure. Pneumothorax. If on the vent, sudden high peak pressure, tachycardia, hypotension, and drop in oxygen saturation. Hemothorax. Similar to pneumothorax, but maybe more profound hypotension and tachycardia. Subclavian injury. This trauma presents as hemorrhage with tachycardia and hypotension, responsive to large volume infusions, usually associated with multiple needle sticks. Bleeding. Again, usually a result of a vein trauma. There is an exponential rise in risk when a provider has over 2 needle sticks to obtain access. If you find a resident looking to make a 3rd stick, it would be reasonable to remind them of this and suggest an alternative proceduralist. CVL occlusion. Make sure the lines are flushed clear post-insertion to avoid this complication. Infection and phlebitis. These happen later, and as discussed earlier, when this is discovered, line removal should be a priority. Central line dressing changes are the responsibility of the RN every shift. This isn't a new teaching point, but rather a reminder to make sure you assess the site and dressing at least every shift. And change the dressing if it's compromised. This means if the dressing is not occlusive, change it. If there is oozing or dry blood at the site, change it. We have a new Primopore line CVL dressings in our CVL kits to support compliance, and we will go over the appropriate techniques later in this training on how to changing them. Document your findings and interventions and review it on the S-bar. How often do we need to change the dressing? Immediately if it's wet, soiled, or if it's non-occlusive. Every 48 hours if the gauze is used to cover the insertion site. Weekly and PRN thereafter. Immunocompromised patients need a sterile dressing changed weekly as well. Most of our lines are IJs, and dressing gets compromised a bit sooner than the week, unfortunately. So this schedule seems more like a dream than the reality. Let's review some important points about CVL dressing changes. Because this is such an important part of reducing infection, we need to treat each dressing change as a procedure, not just a quick task. First, be sure to use a dressing kit. It has all the supplies you need to maintain a compliance with proper procedure. Make sure your hands are clean before you begin. Open the sterile drape and place it on a flat working surface near insertion site. Please be certain to always wear a sterile mask and sterile gloves. Then scrub the insertion site with chlorhexidine. For dry insertion sites, scrub for 30 seconds and allow to air dry for 30 seconds. For wet insertion site, scrub for 2 minutes and allow to air dry for 1 minute. Never fan or blow dry, and do not touch the skin or catheter with your gloves. Apply skin protectant and let this air dry until tacky. Once again, do not fan or blow dry, or touch the skin or the catheter with your gloves. Just give it 20 to 30 seconds and you're good. Apply dressing. Initial, date and time dressing. Document this activity in a CS link. Okay, that takes care of a module 2, central venous lines and their sterile dressing changes. Thank you for your attention.